listening to the Transcend Health Solutions podcast.
All right, this is episode 6 of the Transcend Health Solutions podcast. I finally got Paige on the podcast. She's been trying to duck out of this for forever. So Paige, tell us about what you do here at Transcend.
I am the care coordinator and office manager at Transcend. So basically, the glue that Will doesn't glue together, I glue those pieces together.
Extra glue.
the gorilla glue.
Yeah. So me and Paige, we had this idea to do, a lot of patients will come through ketamine treatment and sometimes before they do, they'll research endlessly about the process. And if you go online and you're looking specifically at like Reddit forums, things like that for answers to questions that are probably best suited by the provider that you might see, clearly there's a lot of people that do that. You know, they go on the Reddit and they ask these kind of complex questions. They get some different kinds of answers, and essentially it would be fun to make a podcast where we just answer a lot of these Reddit questions that are posted and just kind of see if we can create I guess more of the way that Transcend would answer this question. So essentially, definitely have to cover first, none of this is medical advice and none of this is just generalizable. Every single case has to be individually assessed for any of these things, whether we might hold a medication, whether we might give another medication, just what that process might be like is going to be completely different for everybody. So with that, be advised that if we answer a question one way, it might be different when somebody actually comes in for an intake, for sure, but I'll try to caveat all of that as best as I possibly can.
All right, so before we dive into these questions, Will, who are you? What's your background like, and why are you capable of even answering these questions we're about to read?
Sure, so my background is I helped found Transcend. I am a nurse and paramedic. I do clinical work, helping to facilitate Ketamine Assisted Psychotherapy sessions pretty much all of my working week. I'm generally in the ketamine infusion room watching people under the effects of ketamine. So I've done this work for about 3 years. It's thousands of sessions at this point. So essentially my perspective on what ketamine treatment can be like or is typically like for folks and our normal intaking processes or the norms of the industry, I can generally answer these questions about as thoroughly as they can be answered. And so anyway, I'm hoping I can prove that to be the case today.
Yes, and I will second that Will is probably one of the most knowledgeable people that I know on the fact of ketamine, so this will be good.
All right, well, that's the first question.
Alrighty, so the psychedelic tripping effect of sub-anesthetic ketamine for depression and other psychiatric conditions has no therapeutic value. You may as well just take a nap during the infusion and it would produce the same therapeutic effect in the brain. And, again, even though ketamine produces psychedelic effects, it is irrelevant to its therapeutic action, unlike psilocybin.
Gotcha. So, we do have clinical studies where they looked at this, whether or not the psychedelic nature of ketamine is actually useful. And they've even had some studies where they looked at specific aspects, such as even just like the floating effect, is if someone reports that, is that, a marker that might lead to greater reductions in depression symptoms or otherwise. And generally the research has pointed to that what is incredibly obvious to anybody who does the work, but the research also kind of points to the fact that the experiential aspect of ketamine is critical for it to work. So there's not been a lot of success. There's been a lot of companies that have tried to produce, kind of non-psychoactive psychedelics that would have these actions on receptors that might potentially, have these effects. Maybe a company developed something like that, but so far those nearly always flop. So fundamentally, it seems that the concept that these things are separate, that the receptor actions, that any downstream action on depression that is happening is completely unrelated to the experiential aspects. So in other words, it could be that the experience itself is something that launches some of the effects that we see biochemically, and that you see them in tandem, and therefore the experience, it is a pretty critical portion of this. And actually doing the work on a day-to-day basis, I would say this is a very individual thing. So for some people, the loosening of the therapeutic process is probably a lot more important than just being able than the actual experience themselves. Maybe somebody who's had a lot of past psychedelic experience, maybe they don't get as much value out of another psychedelic experience, but maybe they work more therapeutically through the KP process. Somebody who literally gets distracted by the psychedelic experience, sometimes that can be therapy interfering. That is a very rare situation where someone is so awestruck by the experience that they can't do therapy, but that awestrucking isn't also useful in its own way. It's just a pointless awestrucking. Now, in relation to the driver of therapeutic content, sometimes the experience is the driver of that. Sometimes that just kind of intrinsically comes about in the experience, almost like an illustration of the unconscious processing that is unfolding. But generally speaking, I think people can also be too focused on the psychedelic experience versus the therapeutic aspect. They can be hoping that they go in there and experience this really specific thing that's going to move the needle for them, and then kind of continuously chasing that. And so usually that's a conversation with the therapist about does seeking for this specific thing in this experience to move the needle in this specific way, there may be a lot more there with this whole process that we need to go over therapeutically than actually trying to achieve that goal, So in relation to, is the psychedelic nature important? It seems that the research says yes. The clinical work points to yes. And it would be really cool if there was an option that somehow produced those same benefits without the psychoactive effect. That's kind of what they were trying to do with the creation of this ketamine, but that is still psychoactive. And it's possible that the enantiomer or ketamine may be that. They may find out in studies that there are some antidepressant benefits or anti-suicidal effects from being exposed to R-ketamine, which is not particularly psychoactive. But generally speaking, what we've seen so far in the industry is that there usually does need to be an experience associated for the needle to be moved for mental health benefit. That's what it seems so far.
I mean, and without the psychedelic effects, yes, ketamine is beneficial for the brain, but also consciously going through some sort of psychedelic experience that could look like something different for so many people. Like you said, awe. Somebody going through a moment of awe, of wonder, of oh my gosh, there's hope. That sounds pretty therapeutic to me, and special as well, rather than just, being kind of knocked out and getting the benefits of ketamine. So
I guess my wonder is always just what is the hesitancy around the experience? I mean, fundamentally, it can't hurt you. There's not any experience that you can really go through that, actually can physically harm you. It's just a psychological event. Now, that isn't downplaying what a psychological event could be like for somebody. But in ketamine treatment, we have the option of just powering it down at any moment. So there's not really a situation where somebody could go into something where they're absolutely experiencing something they don't want to. Nobody recognizes what's going on because we're right there with the patient the entire time. And they have this full experience of this, whatever it was for them, that they felt negatively impacted them in some kind of way. That situation just doesn't occur in this setting. And that's the beauty of being able to do IV ketamine, is just being able to power that down at any moment. Because if the clinicians ever read that and they were look, this doesn't seem therapeutically beneficial for some, or for someone, and so we can just, electively not be doing that anymore, or guide away from it, or change a variable that might change the experience. So I guess my point is I don't particularly understand the hesitancy to kind of engage in it from a sheer what might I experience standpoint, you know. So in other words, it seems that there's a lot of focus on creating something that's non-psychoactive that produces the same effect, and I just think that, you know, that's more of a just societal, cultural kind of thing. There are, you know, cultures that's not bizarre. You know, this is something that they do since they're children, and there are tribes that give their children ayahuasca, and, you know, this is just something that, like, it's like getting communion at church or something. Like, it's just something that's within the culture. It's never seen as a strange thing, and it's not bizarre to go do this. I just think in our culture we're so opposed to the idea of doing this because of just many years of basically, you know, lots of billions of dollars spent on, you know, drug war, etc., to make it seem as though this is just the worst possible thing that you could ever do. So
also the fear and uncertainty of the unknown too.
Yeah, and I mean, I think that's ultimately what we're addressing with that process.
With therapy.
But again, the ability to just take it down at any moment, you know, it's like if that's ever not therapeutic, or it's ever if ever it wasn't very clear that the experience that somebody was having was going to be useful for them, we can just stop. So there's no real concern there for this thing. I think that this is one of the main things that keep people from doing this treatment, and it's like the least possible thing they should be concerned about, because it actually doesn't happen.
Yeah.
You know, if it starts to happen, we just stop.
It's controllable. Yeah. Each person is different and unique. Some people may really benefit from a big psychedelic experience to kind of change their perspective of things, but because we use IV, we're able to control. If people don't like that and if they don't benefit from it, we're able to lessen it, right, so that they don't have those psychedelic effects but still get the medication.
Yeah, and if I could share my experience on that too. So we used to do some just ketamine infusion, and, you know, so I would be in the room with someone while they're having this, you know, really profound experience, and I'd be like thinking, that's going to move the needle for this person. That's definitely going to fundamentally change them. You know, it just looked like what they just went through was, you know, so over the top, going to be useful for them. And sometimes they'd come back the next week and it was just like rinse and repeat, like nothing had happened, and we do it again. And that's what ketamine infusion only looked like to me very oftentimes. And then continue to move towards doing all ketamine assisted psychotherapy, when there was integration help with this process, even if only small things could be captured from it. It didn't feel like that same rinse and repeat process. So I think sometimes too, and looking at various different clinical trials, when just the experience alone is the only thing, very oftentimes human nature, we're pretty good about just being adaptively hedonic and kind of falling back in the same, you know, rut that we were in pretty quickly if there's not a lot of care and attention to make that process not happen. Like, that's probably what's going to happen to most people that have a big experience, and the needle won't be moved much from it. Everybody's different in that. Some people it totally does. Obviously, you hear those stories all the time, you know, from people like, I did my first, you know, psychedelic mushroom trip when I was blah, and it changed me after that. You know, those experiences are definitely the case. And I think sometimes when we're doing first infusions with people who are psychedelically naive, it looks like that. Like, it sort of shakes the whole situation up and can really interject something into someone's life that maybe brings in a lot of this existential curiosity and everything else, and kind of draws them out of the current situation for a while. But I do think that tends to fade for most people when they are living the exact same life and they're doing the exact same patterns after a period of time. It's very difficult for any one huge experience to really like move the needle in that way. So I would say it's really important as a driver of therapeutic content. By itself, it can be useful, but likely without a lot of individual, you know, integration help and all of this that somebody's doing, it may not move the needle for forever. That doesn't make it a worthless, you know, venture for someone to do. Obviously, regular ketamine clinics help a lot of people. But anyway, I guess my point is in relation to how important the experience is and what it's useful for. I think it's probably a fairly complete answer to that question.
Cool. All right, ready to move on?
Yeah.
Okay. All right. Is ketamine recommended if you are not on a proper mood stabilizer? The reason I ask is because I've had adverse reactions on the mood stabilizers I've tried for depression, which is why my psychiatrist recommended ketamine.
So are they asking if you shouldn't do ketamine treatment unless you're on a mood stabilizer?
Is ketamine recommended if you're not on a proper mood stabilizer?
Well, let's just talk about mood stabilizers and ketamine treatment. So there are very few medications that do interfere with ketamine because it has its own mechanism of action. So people are common to hear, being on antidepressants and doing something like MDMA assisted therapy. They kind of hear that if you're on an antidepressant, you probably shouldn't be doing these other psychedelics, which, is a very complex topic there. But long story short, ketamine doesn't interfere with most of those medications. So the majority of the people that we see are treatment-resistant depression. And it's common to see people come in 3 to 5 different psych meds, SSRIs, SNRIs, etc. And that's not an issue for us, to do ketamine treatment with them. There are a couple of medications that we, do advise people to oftentimes hold. But again, these are case-by-case situations. So some patients will hold them, some patients will not. We have to stratify this, with every single situation. Because as an example, maybe, in relation to mood stabilization, a common one in ketamine to come up, a common one is Lamictal or Lamotrigine. And so, generally speaking, if someone's on Lamictal, the level of ketamine that they will experience at a certain dose will be somewhat lower. It'll be more blunted. You can just get more ketamine. That's a pretty simple situation to sort out. Sometimes on very high doses of Lamictal, or the people that are particularly susceptible to this phenomena, it becomes a little bit difficult to achieve a great plasma concentration of ketamine that would be useful for KAP. That's so rare. So in that situation, we would likely be saying you should hold that medication prior to the session, or potentially taper down, depending on how much somebody was on. So another one would be like benzodiazepines, as an example. But some people may not be able to do that taper or that hold. So that's a case-by-case scenario. So there's plenty of people who don't do any holding or anything around that medication, and we still facilitate sessions with them just fine. And there's even more studies now on that particular interaction not being an issue for ketamine treatment, that it doesn't play into the antidepressant effect.
Yeah, I think I want to reword this sentence. I feel like they're asking, is it recommended for them when most depression medication has not helped them? So if they're not on anything, nothing has helped them. Is ketamine recommended for that sort of person? I
mean, that's the cool part about ketamine, and there's good studies to suggest that sort of the sicker somebody is in this way, the more severe symptoms, the more medications that they've tried, the more things that they've been through before they get to ketamine treatment, the greater the chance for success with ketamine treatment. And so, and I've definitely seen that, in the care, that it's actually kind of confusing for the clinician, because sometimes you can intake somebody who's like so severe, and you can be like, well, I don't know if anything might be able to help that person, this or whatever. And like, those are the cases that like tend to respond the best. And so you're oftentimes, surprised, when it works really well for the most, critical cases. And so, whether somebody's on, tried multiple medications, mood stabilizers, TMS, ECT, etc., that doesn't, bar them from having success with ketamine treatment potentially. And so, I think that probably answers that one, all right?
Yeah, I think for most people that that's treatment-resistant depression, right? If depression medications don't work for you, like, I will second that, since I also work here, that most of the time those cases are the most success. For some reason, their brains just need that modulation of glutamate and not that SSRI or whatever they were on before.
Or maybe even just kind of fundamentally a different approach. I mean, if someone has been really down the biochemical road of, this belief that their brain is broken and that there's going to be this, concoction of chemicals that is going to fix that brain, or at least, provide some relief for a period of time, and they've just been after that road for many years and not found any specific thing that works. And maybe they tried therapy too, but doing something that is so directed to the core issues that may be afoot for somebody. Not always the case, that there's some core stuff there, but it very often is the case that the majority of the people that come through that have treatment-resistant conditions so far, we do address things that just haven't been addressed yet. And so that's oftentimes how we're kind of moving the needle, is that ketamine can help people to undergo therapy that might be too painful to do under normal applications. And so it's easier and more possible to get into those things that are more someone would never probably do in the normal therapy room. And so anyway, I think that in relation to all of that, honestly, I forgot the question at this point, but what's the next one?
All right, is ketamine just for a bit or more? Oh man, it's a good way going. All right, is ketamine just for a bit or more long term? I'm currently on Topamax, and it is nice, but I'm certainly sleepy, still getting used to it.
Yeah, so that's another case-by-case scenario. So there are people who come in and they do 3 sessions and they never do a KAP session again, and they get significant benefits and it just sticks, and that was exactly what was needed at the time, and everybody high fives afterwards, and it was just a really cool scenario. And then there's ones that are tougher than that, where people do a number, they're in that 8 to 10 range for a normal original KAP series, and then discharge, and they're able to kind of maybe need a few infusions throughout the next year. Obviously, probably a more complex case with some situation like that. There's those situations, and then there's people who the smartest possible thing is just maintenance treatment for them. So obviously chronic pain patients, that's usually the case. Keeping pain down without some kind of maintenance is very, very difficult. Not impossible, but I've seen people who have reductions in symptoms that just lasted. It's not even supposed to do that, but sometimes it does. I guess the point of that is that it's important for this to be tailored to the individual, and all kinds of factors can play into that. So how good of therapeutic support they have outside of, are they concurrently working on lifestyle modifications? What are their goals ultimately? Is it to get off of all medications? Can we find a stabilization on the medications that they're on in this process as well? So it's going to look different with all of these cases, and the severity that somebody comes with as to how many sessions somebody might need, and whether this might be a more long-term thing for them. But I would say that it is a rare situation for us that somebody comes through and just right out the gate, I'm expecting a lifetime of maintenance, getting treatment for somebody. Generally speaking, that approach is far too overutilized in the industry. It's usually a business decision to do something like that more than an actual clinical decision. We should always be with any medication you get or any modality, whatever, it should always be, what are the risks versus benefits of this specific one on this day. And I think if you're really weighing that, you're going to rarely find somebody who definitely needs this every single 30 days for the rest of their life. It's just, it's a rare person to find that does, but they do exist. That is the smartest thing for somebody. But I think fundamentally, PRN treatment in this way is probably always going to be more advisable than just a set schedule that is a little bit more mindless to what somebody really needs at a given time. But there are some people that predictably every 30 days, probably should return. So, I would say that it's not, so to answer that, is it for a short period of time or a long period of time? It depends on the individual, it depends on the severity that they come in with, what condition that they're having treated, and then just what is the potential for relapse from these symptoms post initial series. So what we do is we have an auto dialer that we can set up any cadence, but every 30 days we're, hey, how are you doing? Hey, how are you doing? If that dips at any time, we're ready to come in and intervene at that point. But we're also going to try to see if we can intervene via similar means. It may not always be a ketamine treatment. It may be, hey, we need to see you twice a week for therapy for a portion of time, or in fact, this other referral is the smartest thing at this time. But it's not always to jump to ketamine assisted psychotherapy. Oftentimes with once a person is more stabilized with their distress, if it does spike back up, that is usually recoverable without KP, but sometimes not.
Yeah. And also, if we do see patients, not necessarily long term, I think, but maybe once a year or whatever, everybody's different. So we see some people every 6 months, every year, every 2 years, like whatever it is. I think once people have a successful series, which that part is the short term, 6 weeks maybe, weekly infusions, that short-term bit, and it's a successful treatment in that time. From there, I'd like to see ketamine as just like a tool that people could use later on. Like, you're drinking coffee right now, right? Like, you don't need coffee every day, but you might have a really rough day, rough sleep. I need a cup of coffee. That's a tool that we would use to kind of give us a little pick-me-up or whatever it is. So when somebody has a successful series with ketamine, I could see them utilizing this as a tool in the future of like, man, I'm going through a lot right now and I feel like I'm getting a little bit more depressed. Let me kind of just let me go get my support system and my team and like talk to them about it. Let's talk through this. Even though I'm capable, like this will be helpful for me in the moment so that I can keep pushing forward.
Yeah, I mean, I think oftentimes the sort of core things that somebody gets out of an initial KP series, sometimes it's easy for those things to fade, and oftentimes one infusion at the right time is the right type of reminder that you just couldn't give it any other way towards something that is fundamentally known towards somebody, about what their purpose is, or about just, seeing a certain perspective on their entire situation is just really useful for them. I mean, that's what it looks like so oftentimes. My favorite utilization of kind of more long-term use of this is when patients are working with their normal therapist and they come in and they're like, I've been working on this with my therapist, I ran into a roadblock, and like I want to do it in this capacity, and that's what I'm focused on with this work in a short series or otherwise. And that's awesome when we can see it used in that way, because then someone is in active distress from this, but they're like, it just shows that they're doing continuous therapeutic work outside of the ketamine treatment, because we just never want it to be that ketamine is the answer for all problems. So that is that's not a useful thing in any medication that I found this lucky chemical that just happens to work perfectly. There is no biological free lunch. It doesn't exist. Everything that you interject into your vessel, there's going to be a slew of consequences of that, good and bad, and we have to stratify all of that, and that's the act. That is medicine in a nutshell, is trying to do that art. And ketamine has its similar, possibilities that come up with anytime you interject it, so you don't want to be mindless about that. And so, it just really comes down to being intentional with the process. And it's easy for, we're a clinician-owned entity, so like this is just at the core of us that, what somebody really needs, the actual patient, that's what we do. We don't have any push in any other kind of way that could come up in business, and that, it's just like, well, let's sign up everybody on a 30-day maintenance plan, and let's just tell everybody that that's what they need. And we've never wanted to do that, from day one, because we're like, what is that? Is that what's needed? And if I found evidence, that studies came out and they're like, nope, like the smartest possible thing with all things considered is seeing people every 30 days, we'd switch to that, we'd follow the evidence, but I wouldn't say it's there yet. I don't think there's hardly any study on long-term maintenance of ketamine for any great period of time, but that's like a topic for a whole podcast. That's like probably not ever going to be done, and probably not ever going to be done for any antidepressant or any other medication that's out there either. I mean, getting data on what it looks like when somebody takes, as an example, an SSRI, an individual one, over 20 years, like getting that data, like we don't have that stuff, so like expecting that in ketamine treatment, like oftentimes I'll hear patients say like, what are the long-term effects of this? And it's just like, what are the long-term effects of the 5 medications that you're on? You would assume that to be FDA cleared, something would have that data. Not always the case. In fact, usually when we pull that data, it shows that it's very harmful, and it gets a black box, and then everybody ignores it and just keeps prescribing it. And inevitably, I'm starting to sound like anti-med on this. I'm not anti-med. I think they definitely have their use and their role. But I just think fundamentally, if people didn't have to take them, they wouldn't. And that's a lot of people's goal in treatment. to not need to or want to anymore, and it's fine if that is the best balance point for somebody, or they actually are useful, because medications don't affect people equally. Ketamine isn't the same for everybody. An individual SSRI isn't the same for everybody. If it's helping you, that's the thing to do. But if it's not, or it hasn't worked, and they're just kind of on it at this point for no reason at all, to me that feels just mindless and something we could work on.
Yeah.
So, next question.
Alrighty. Adderall and ketamine therapy, yay or nay?
All right, so again, individual situation here. Generally speaking, I think fundamentally, like, what is Adderall for? It's to help people focus. There's not any need to be, that's like a completely opposite frame of mind than what we're doing with ketamine. Like, we're not focused on the present here and now at all under ketamine. In fact, we're dissociated from this reality in its entirety and experiencing everything you experience at once, oftentimes. And so those two, like, just brain states just fundamentally aren't really paired well. It's almost better to go into a ketamine session sleepy than it is to, literally people come in and be like, I didn't sleep all night. I'm like, probably good, to be honest. You know what I mean? You'll naturally just kind of go into this. You want to like go into it and relax into it. So, basically just that stimulation is going to increase anxiety, heart rate, hypertension. So let me take a breath, because this is kind of a complex topic. So essentially, ketamine stops the ability to reuptake certain aspects. So essentially, catecholamines, what can happen is you can deal with runaway hypertension or runaway tachycardia if you're taking medications that are stimulating your system. Now, clinically, when we're giving really small doses of ketamine like we do in ketamine treatment, and people are on reasonable doses of Adderall or Vyvanse or Ritalin or et cetera that they've been taking over a long course of time, the chance of seeing this effect where it actually harmful physiologically is just not very high. I've had patients who came in and like after the infusion were like, oh, I took my Adderall earlier today, I'm like, oh, yeah, your heart rate was up slightly, 10 points more than normal, and they didn't notice too much different. But generally speaking, I have seen patients who, are on higher doses of stimulant medications, like just really not be able to relax into the experience, or just really struggle with the kind of letting go process, because those two just don't pair well. And so I don't think that it's smart physiologically needed in any kind of way. It wouldn't be more useful or anything like that to be focused on a ketamine experience or something like that. And I just think, although the risk is not necessarily high, it's like, why are we playing this physiological game right now? Like, why would we even risk that at all? And so I just think in general, it's pretty much always best to hold these things. But again, case by case, I have had patients where we decided not to hold their stimulants because it was, maybe if they've been taking them for a really long time, it's kind of detrimental to hold them for a day. They're like, man, going to a ketamine session, I literally felt like a slug because I've been taking, 40 milligrams of Vyvanse for 10 years, and they told me not to take it. It's like, that may not be the best state, and the Vyvanse may not be particularly horrible for them in that situation. So, it's case by case, but generally speaking, it's going to be a hold.
Yeah. All right. Can you undergo ketamine therapy whilst trauma is ongoing? I think that's a really good question.
Yeah. High five to whatever editor put that one up there. Mm-hmm. So, this is an interesting question. Yes, you can, do it. And I think that sometimes when there's anxiety about doing treatments and it's a big undertaking, everything, we can kind of come up with any reason why we shouldn't do it. But the reality is like timing is probably not ever really going to be that right for this process. People will really try their best, and that's great that they're trying to be as intentional as possible about this. But the idea that life is just going to stop for 6 weeks and nothing's going to come up during that period of time, and that's rare in anybody's life. And so I think oftentimes this is just trying to come up with some reason not to do it at the moment for most people. But in relation to ongoing trauma, I do think that we have some some real concerns. So one would be just that this might be too much for somebody at the time. So in other words, if you're doing deep therapy work, you're also having a lot of stuff come up in the day-to-day that requires processing in and of itself, and someone isn't like tremendously supported, with outside therapist and maybe even potentially more than that during that process, yeah, that might just redline someone's capacity to at the end of the day be able to, it's just going to flare to stress mostly. It's just too much all at once. And then, I mean, in general, we've actually had these situations in the clinic before. I think sometimes too, so sometimes a little bit of treatment can help somebody like get out of these situations. It's like when you're dealing with incredible depression, seeing a way through out of a situation where you're in an abusive relationship or something like this can be so difficult. I mean, literally reality starts to look different when we're in deep stages of depression. The idea of coming up with ways out, solutions, etc. Sometimes treatment is required just to get somebody to a baseline where they can start to fend for themselves and realize, like, hell, I gotta get the hell out of this relationship, or I gotta, do this. I'm financially dependent on this person, and I gotta put out, some job applications. Like, sometimes, that has been useful in the process of getting better and then getting out of these situations. But I would say, I think where that concern probably comes from people is in relation to this idea around neuroplasticity, right? That the idea that we gotta, that we're gonna remodel our brains during this process, and that we should control every variable imaginable to make sure that happens as best as we can, in this process. And I think people tend to get in their heads a little bit too much about that. I think you do what you can and you go on about your life during the process and you try to integrate these things, but like, I think to the degree in which somebody feels like, I don't know, that either they shouldn't see treatment because they can't create a space for that, or that, their treatment has done nothing because then the days after they, had X, Y, and Z happen, a really stressful job or whatever. Surely if you can create space for all this, it's going to go better, 100%. But, to be able to take the time to really do this deep work. But I don't know if we can always expect that in life. And I think that worrying about maybe that neuroplasticity side is just kind of, we don't have enough data on that to really know what you should be doing, in between sessions, or how much it makes a difference or not. I think people tend to like leverage it like it's going to be absolutely useless to have done ketamine treatment, but we don't do that in a normal therapy room. We don't do that around EMDR. We don't do that around all these other things. We're like, oh my God, I did this therapy session with my therapist, and then, I went to a really stressful day the next day at my work, and like my therapy session was useless. And, we don't do that. And so I just don't really think that we should probably be over leveraging it to the degree that we don't see treatment, or, think that our treatment has been derailed by it. It very likely hasn't.
What about if, let's say, someone is coming to get treatment with us and they are currently going through like ongoing trauma, and when they leave, like let's say the person picking them up or the home that they're going to are kind of like the source of that big trauma, so they're coming from here to there.
Yeah, I mean, my two thoughts on this are like, if this situation is going to remain constant without intervention anyway, like what's the potential negative, But I guess my point in this is that if we can create, fundamentally to do ketamine work, you have to create not only a safe place, but like the safest feeling place. The people that you're in and around during ketamine, people can't really progress through the ketamine experience well if they're constantly concerned for their safety during. Those mechanisms are going to come online big time when we dip into our unconscious processes, when we're actively going through that. In other words, people may check for their safety more when they're regularly not safe in their home environment. And, when that's appropriately supported, that can help with that process of the nervous system always being like, oh my God, am I safe? Am I safe? So if we can create a space where that actually is the case, that can only help that situation. That can only let that person's nervous system really dwindle down for even just a portion of time. And if they're going to go get back into that situation, obviously from a case management standpoint in the clinic, we'd be trying to help out with that entire situation if that came on our radar as happening for somebody. But and that could be critical in their treatment, that they get to a safer place, and that regardless of ketamine treatment or otherwise, that might need them more than anything. It's just them getting out of that scenario. But But again, sometimes getting out of that scenario is a really complex thing for people, and I just wouldn't let it stand in somebody's way from seeking help and at least providing some reprieve, even for a portion of time, if they had the resources to do so.
Okay, this next question kind of goes into all of that, just words it a little differently, but let's just say we're not in like ongoing trauma, but today is just really rough. Like I woke up this morning, my freaking boss is yelling at me, my kids are being crazy, like I'm having a rough day, I barely slept or anything, I'm just really mentally not here and don't even really feel like even talking to the therapist. I just want to take a nap and for things to just stop.
Yeah, come in anyway. Seriously, like, I mean, so there can be a lot of anxiety about coming in and doing this, and we're going to want to like get every variable lined up, you know, and that's awesome if we can. But you know, if you're having a bad day, that content is like fresh and brimming in the unconscious and just ready to be processed. And like those are very oftentimes the best possible sessions. So when someone's like in the middle of the breakup with their, you know, girlfriend, and they like have been fighting all night, and they come in and they're like, I don't know, you know, like if I should come in, it's like that's usually a great session. When things are, you know, kind of fresh on the mind, people will say like, oh, that's a reason to not do it. It's like, well, no, that's more of a reason to do it. You know, if something is particularly triggered at the moment, prime opportunity to work on it. It's no therapist is out there like trying to trigger their patients to get these things coming up, but exposure to these things repetitively is part of the process most of the time. And so it can be very difficult to want to get on the horse and like sign up for that situation. But the reality is ketamine is only going to make it easier. It's only going to be easier to process that under the effects of ketamine, very likely for most. I mean, even if it's cathartic for someone, a lot of times when they get done, they don't really report catharsis. I mean, you know, people will really go into a specific topic, have those emotions come forth big time, and afterwards just be like, I remember a pretty serene experience, and they're like, you don't remember the part, this thing, and they're like, well, a little bit. You know, they will sometimes deeply process something and barely recall it afterwards until it's sort of prompted, and they're like, yeah, I do remember that, and the therapist has more opportunity to work on that content in our conscious state. But I guess my point is, you know, the odds of those types of things coming up when they're like really fresh on the mind, really high. So that's a prime opportunity. In other words, if people are pissed off, agitated, today is just not the day, all of those processes, those parts are fully present, like that's a great opportunity to work on those parts. Mm-hmm. You know?
Yeah, it's therapy for a reason.
Yeah, but yeah, no, don't just wait for a good day, because I mean, in the treatment-resistant populace, waiting for a good day, we're going to be waiting a while. Mm-hmm. So,
yeah. All right. Anyone else finding the benefit of nasal spray tapering off quickly? So I see that as the benefit just seems to dwindle as they keep going.
Yeah, I mean, we'd have to have more questions. So we don't do any intranasal or oral ketamine prescription largely for this exact issue. Is it intolerance pretty rapidly? You know, people can start escalating their dosages. Eventually, that has a high end. That's the way it is with nearly all medications. You know, and I've been through that, you know, medically, where I'm like, great, this new medication's helping, and then now it's not doing anything. Let's up the dose, and now it doesn't do anything. I'm taking it for no reason. Like, this runaway tolerance issue is the case for a lot of medications. And so, in relation to just using ketamine nasal spray, I'm assuming this person was probably doing it regularly, like maybe every night or otherwise. Very shortly, that tolerance is going to build, and there isn't going to be, you know, much of an effect experienced. And then in relation to, like we were talking earlier about the experience being useful and things like this, even if we're just doing low doses of ketamine more regularly, chances are that tolerance is going to build. You're going to see less and less benefit, and then you're going to, you know, the physical withdrawal from ketamine is not significant. So it's about the same as coffee, marijuana. That isn't downplaying. Well, if I don't drink a cup of coffee, I drink it every day. If I don't drink a cup of tomorrow, I'm going to have a splitting headache. I'm going to really want to just drink a damn cup of coffee. But at the end of the day, I probably could if I was really like motivated to not drink that coffee that day, right? Ketamine's about the same. So, you know, there can be a really strong urge for that if someone just abruptly withdraws from, you know, a tolerance level of ketamine. But it's not going to be, as significant as it is for a lot of other things. So, I think that's why some providers have felt more comfortable to prescribe, to patients for their home, either smaller doses and sometimes really high doses, which has always really been pretty surprising to me. But I guess the point of that is yes, that would be a normal effect seen in most medications, but ketamine too, that would be utilizing ketamine as a biochemical solution for an issue that may or may not have a biochemical, look for the word here, origin, I would say. Not that it doesn't have those corollaries, but origin. And I guess the point of this is, it's just that it's why we don't do it, and there really isn't any good evidence to suggest that we should, like microdosing ketamine in between sessions or microdosing it more long-term or more long-term use of it. We don't really have a lot of data on this. So what we do have the data on is, doing it kind of like how we do it, where you administer it by IV with a therapist there, and in this process to facilitate psychotherapy. It's really what we have a lot of data on, and I just don't think that, me personally, if I was going through this, I would want to, regularly use it just for the chemical sake alone on a more long-term basis, because I think that if we continue to see more evidence that the ketamine can bring about a more neuroplastic state in the brain, being constantly neuroplastic is not a good thing. This buzzword is a very complex thing in a neuroanatomical, neurobiological sense, and so I think sometimes people feel that they understand neuroplasticity quite well, and the more I've learned about it, the more I just reserve to. I don't know anything about that process. The people that you're talking about it more broadly, it's a lot more complex than just like, brain just rewires something. Your brain is constantly doing that. And we need to form hard associations. One of the concerns potentially for schizophrenia, again, not a proven hypothesis, but the theory is that possibly these brains remain neuroplastic over a long course of time, and forming hard associations becomes really difficult. And so I'm not saying that long-term ketamine administration causes schizophrenia, that's not what I'm saying, but I'm saying that, being in a constantly neuroplastic state is not a positive or beneficial thing. And, we don't even, time will tell on the neuroplasticity aspects of ketamine. It may just be the novelty of the experience that is the launcher of the neuroplastic sequelae that we pick up on that says that the brain is probably in a more neuroplastic state after ketamine exposure. So we don't really know, all in all, everything there is to know about ketamine and neuroplasticity, but if it's the way that it seems, it wouldn't be positive to constantly be doing that, That would be, I don't know, hitting the gym every single day. I mean, you're constantly breaking down the muscle and never getting an opportunity to rebuild it. I mean, I guess that analogy fits okay, but the idea would be to, do the work and then recover from it, There was a reason why we only do like one session a week generally at Transcend, is we want to kind of start that process and then allow that process time to solidify and kind of take effect, and then go again when the timing is right. Not just constantly keep a brain in a neuroplastic state indefinitely. That likely, we have no idea, but likely would not be positive.
Mm-hmm. Okay. At the cadence that we do IV ketamine, does one build up tolerance in that way?
No, we don't ever do, so if we're going to do 2 in a week, we always put a day in between. So I've done sessions where, the only way the patient could book it would be like, they were going to be seen on a Monday and then a Tuesday. And sometimes when you do that Tuesday infusion, you're already seeing a tolerance there. But even if you were to just hold for another day, that next day you probably won't see much of an effect. So I think it's pretty important to essentially space these things out for a lot of reasons. I mean, there's therapeutic reasons for that, there's chemical reasons for that, and I just think too, comparing it to like, recreational psilocybin utilization for a similar process. People don't do psilocybin and then the next day do it and then do it every night. I mean, people will do a big experience, get what they can out of it, maybe not do it again for 6 months or maybe the rest of their life. And I think that we could probably take a lesson from that to some degree of like really holding this sacred and not letting it be, an absent-minded thing, getting the most out of it and really trying to capture everything we can from it before we hit it again. Because what you can risk is really big things coming up in your experience, then going right into the next one, really big things coming up, and then really big things again, and just like never any of that stuff got time to actually like kind of
process.
Yeah.
Okay, cool. All right, so can ketamine therapy induce hypomania?
Yeah, this is an interesting one too. So, possibly is probably the best answer for that. Mixed data so far on whether that is the case. There are kind of more people who've been working within, this space, will have reports. But I think, one of the kickers of this is like, so if somebody's susceptible to hypomania, and let's say every 2-3 weeks they actually have this, or even deeper stages of mania, if they're going to infuse for 6 weeks, it's very possible that sometime in there, they're just going to have a normal swing of that. It is probably more likely when there's stressful events in their lives and things like this. So when we're processing things, that can be kind of stressful, so that can be an elicitor of it there. And then there probably are some potential more biochemical things at play that could potentially induce this. But the reality is when we treat bipolar patients, I rarely see one that they have a really characteristic, like I did an infusion and the next day and then we wait a while and then we do another infusion and the next day they're manic. It tends to just be sometime during a period of time that probably would have came anyway, not at even a more great cadence than they would typically experience. So that's what I've kind of seen, and we've treated a good number of bipolar patients, but we usually don't treat somebody who's already manic, with ketamine. It might be difficult to get a lot out of that infusion. I'm talking even just if someone's maybe hypomanic, the clinician might make a decision that it isn't the smartest thing on that day, but particularly if that's like essentially their baseline. But the reality is there is it's a important consideration in treating bipolar that there's a regular screening of that potential, and because deep stages of mania can get pretty serious, they can need a lot of support, they can get dangerous even. And so it's important that as we proceed through this, that we're being really mindful to be assessing for it, and the patient's really mindful that that's a potential risk and can report that back to. The actual risk, I'm not really sure of. I've seen a lot of, I'm not sure if I've actually seen that many cases of this, and I think eventually we're probably going to see more data that says it's probably not a really large risk, greater than, a lot of other things. So I guess I expect to see less and less evidence to suggest that we should not ever, bipolar 1 patients, et cetera, be treated with ketamine. I think we're going to see less and less of that evidence over time. I just think it takes a lot more support. So if someone has bipolar disorder and they're thinking about ketamine treatment, they should definitely be doing ketamine assisted psychotherapy, because, sometimes it's difficult to tell what state you're in on a given day, and it'd be really obvious to a clinician. And so knowing whether it's a good day to infuse or not, being able to track the trends of what's going on with somebody to say, is this potentially invoking more mania, or is it helping the depression greater, stratifying all of that? You need a clinician to help out on that. And so just going and getting ketamine infusions or getting mail-order ketamine to someone who's bipolar is, a lot of those places refuse someone with bipolar anyway, but the point is that it's not really that advisable from Will's opinion.
All right. How does long-term ketamine treatment affect memory?
Again, going to the data, long term, trying to say what that means. What we do know is that if you use ketamine in very, very high doses, very regularly, over a course of time, you're going to have brain damage and memory deficits. Dosing is pretty critical and frequency is pretty critical in what effect we may see. So there's also studies that in the more clinical setting of ketamine administration, there can be pro-cognitive effects, potentially, and then the possibility of sort of memory retrieval even, or like in studies around dementia as an example, there can be some possible benefit there. And so, I think that the research is early in saying whether or not it improves memory or, possibly hurts memory in any kind of way. But, my guess is that we would see is that with really careful, small time limited amount of ketamine series, we'll probably see that there may be like some pro-cognitive effect for a period of time, and then that will probably dwindle after a while. And that probably doesn't result in any long-term memory loss. That's probably what I would guess that we would see from this, but I do think that if you're doing high-dose ketamine infusions weekly over a very, very long course of time, it is unrealistic to think that you wouldn't have some kind of negative sequelae of that. Just because we know in the most extreme, setting of addiction and abuse of ketamine, we definitely see that effect. So it would just, for me, there's probably a curve to this thing of where, just like any other dose curve, that there's an area where it's useful physiologically and beneficial, and beyond that, we'll probably see diminishing return and then negative side effects, as you escalate that more and more. So basically, we don't know is the kind of answer to that question fully, and probably we're going to find that there's no risk for this in a short course series or more intermittent use, but we're not going to probably find that high-dose regular use is just like completely without any concern. Mm-hmm. I mean, I keep like breathing all the way up when I'm trying to answer long questions, and then my lungs have been so full. Anyway, so I guess we go to the next question.
So, but how does a small dose, short-term treatment of ketamine, how would that affect memory?
Yeah, I mean, I think if we're just, depending on whether we're talking about short-term memory, long-term memory, memory is a whole study, mm-hmm. But I think generally speaking, we don't have enough data to say exactly whether or not it would hurt or harm. Mm-hmm. My guess is probably small doses in the acute phase is probably going to show there may be some potential benefit. We see, data on increased global brain connectivity and, just a lot of...
What does that mean?
Yeah, so global brain connectivity, the idea that basically, these parts of our brain are communicating with each other or not. So again, this study, you can kind of look up the researcher Lynette Averill. There's a pretty good paper that talks about basically global brain connectivity and ketamine administration. And so I think that that's it's very possible that we're going to see some benefits to this, or potentially people have damage to this, dementia. We may see some benefits, but I doubt that we'll probably have this as the indication. In other words, memory loss and dementia, ketamine treatment is the mainstay, standard of care, approved treatment for this. Even if it starts to show those effects, I have a hard time believing that you would see such a pronounced effect with just ketamine administration only. That this would be super useful in that populace. That would be worth, bringing somebody through a psychedelic experience to achieve. Well, we'll see. I mean, there may be kind of therapeutic techniques revolving around therapy that could be used in this stage that might potentially help significantly with memory and dementia in the elderly. Something we've discussed in the clinic is the possibilities around that, and did a big literature pull on all of the ketamine research related to dementia. There's some interesting evidence there.
Cool. Okay. So I found out my clinic has been mixing Benadryl into my IV ketamine. Is this normal?
I mean, I wonder how to answer this question. So, I think that prophylactically treating everybody with something is generally not the smartest way to go about most processes in medicine. You know, I'm just saying everybody needs this. There are some patients that might benefit from having a little bit of Benadryl before their ketamine session, in that it might essentially produce a sleepier, less anxious state. Most people know what it feels like to get on Benadryl. Doing that for all, I feel like is definitely probably overkill. But there's not any known synergy specific to that. It may be that they're also like administering Phenergan, and they're trying to use that as an agent to reduce the risk for dystonic reactions or treat it prophylactically, which that's too technical probably. But the long story short is if it's useful for someone, there's probably there's no evidence to suggest that if someone gets Benadryl and they get ketamine, they're gonna have less effect from ketamine. So it's probably a fairly benign thing. Now it's definitely gonna make the recovery a little bit longer, because if someone's getting 25 or 50 milligrams of Benadryl IV, man, it makes you sleepy. So when you get done with that ketamine session, that's gonna be in full effect, and you're gonna be sleepy already a little bit from the ketamine treatment, and just the added Benadryl on top is like kind of a lot. Now, maybe they're seeking treatment for like migraines or something like this, and there's some other indication why they're getting that Benadryl. But my guess is it's probably related to trying to keep people calm, and that's we don't administer any like prophylactic benzodiazepines or Benadryl or anything like that for our treatment, because we kind of want those things to come up so that our therapist can help to work with those things that come up. And so, in other words, if someone is a little bit anxious before, we see that as a positive thing and something that we can work on, and an opportunity, not something that we just like prophylactically give, a medication to hopefully blunt. I just think fundamentally that's not, if we're after long-term goals, that would be an action that would not be useful for long-term goals.
Okay. Cool. All right. How spiritual is the experience?
All right. Well, I've definitely seen people have some spiritual experiences under ketamine. After thousands of sessions. I mean, there's, it's pretty regular in the clinic for somebody to have that experience. But I think the experience isn't fundamentally any one thing or another. It's very dependent on the individual that receives it, or what it might be like for them. And so someone who has a openness towards spirituality may have a more spiritual experience, or be more likely to see that process than somebody who is very closed off to that idea. And so I heard Matthew Johnson talking about I think he was discussing maybe what if they did sessions in the Bible Belt, what would be the likelihood of seeing, people have more, Christ imagery emerge versus the odds of some other deity emerging, or if you were in a different part of the world, what would that likely be? So I think that somebody's openness for that to come in, because I've actually seen patients who are agnostic or atheist who were in the midst of a experience that most people would term like a spiritual experience, and they literally were like, what is this, God, get out of here, I'm trying to see some colors, you know what I mean? Literally just no openness to the idea of this thing that was coming up in the experience for them, and just shrugged it off and moved back and powered through it. So I think the openness to have that type of experience would increase the odds, whether that's in somebody's framework or not. In other words, if someone's going in there searching for a spiritual experience, it's probably more likely for them to achieve that type of thing. And that term spiritual, what one person would call a spiritual experience, another person, that can be really different. So, because I've seen people have things that I would that sounds like a spiritual experience to me, but that's not the way that they would come back and report that. Mm-hmm. And so, how spiritual is it? How spiritual is the person that's receiving it? And then, just do they feel open and safe for those types of things to come in? And also, does it need to be? I think it's completely fine if somebody has an experience that, you know, some might term as a spiritual experience, and they just, you know, want to shrug that off. I mean, I guess my point is it's not a necessary part. I mean, there is some data around the mystical experience, right? Producing antidepressant benefits, but I think mystical, spiritual, etc., how all these terms, like, I don't know fundamentally if we really know what's happening to somebody in that actual experience. Enough to say that this person had, you know, this exact effect and they saw this or whatever else it may be, and then that's useful in the treatment of depression or not. I mean, because even if somebody experiences it, likely they're not going to remember too much from that actual event, and it's how they know to internalize that, create narratives around it, you know, work with it on the day-to-day that are going to make the difference in the long term. And that's somebody's option, or that's somebody's, you know, option to not go through that process. So regardless of what the experience is, it's ultimately going to be, you know, that impact that's going to have on someone's life is a way broader thing than just like having the spiritual experience. Because like I said, you know, I've seen people just have spiritual experiences and like come back next week like nothing happened. So, you know, when not supported.
Mm-hmm. Okay. So my second experience was basically nothing. Why is that?
Yeah, I mean, I'd have a bunch of questions around this, but you know, I think I can answer it a couple different ways. So it's funny, I actually saw this ad from a company that does oral ketamine home prescriptions, and they had this post, and it was about what if nothing happened during my experience? You know, like, what does that mean? And it's like, well, I mean, there could be a dosing issue here, right? Like, with particularly oral ketamine home prescriptions, it's pretty common for one time to hit really hard and one time to just not do anything. So probably this company's getting like all these inquiries like, I took this one and didn't do anything. And there can be reasons like compounding, ketamine issues. There can be just a lot of, so, you know, when somebody a slew of different reasons why somebody may experience more or less on a given day from oral ketamine administration. On IV, we see that too, but the difference is we can titrate as we go. So, you know, if I administer the infusion the exact same way 5 times on completely different days for somebody, you're probably going to see a slightly different level achieved with that exact same dosing in the exact same way. So we titrate for that, you know, to correct for these variables, and that's, you know, foods in someone's diet that are potentially interfering with, you know, how quickly the ketamine is clearing, or all of these types of things. You know, how much anxiety somebody has had on a given day, how well they sleep the night before. All this changes us essentially biochemically, and of course we can expect a slightly different response when we interject the exact same amount of milligrams, you know, down to the 0.0 mil per hour into somebody, and seeing these like deviations of what level we achieve. It's not ever going to be consistent, and when you mix in a variable of intramuscular, intranasal, you know, or oral, sublingual, rectal, etc., you're going to see a lot more variation than you see in IV. So even doing it with an infusion pump where it's like completely, I can make it exactly the same each time, you know, down to the milligram per minute, you know, even with that you see variation, let alone when you do it orally, where it's like kind of a crapshoot what you're going to get on a given day. Some people it is consistent, you know. Some people it's a pretty consistent experience every single time, but generally speaking you expect variation. And so that's one thing that it could be, is just the route of administration, not a lot happening in the day. That's okay. Someone would just try again, you know. Another one is that there is a very odd phenomena, you know, where basically, you know, someone comes in for their first infusion where, you know, there's a lot of anxiety about doing it, they're very excited about doing it, they're nervous, all these things. And that plays into the experience. So it can feel pretty righteous and like a lot's happening, and really just, you know, the first one sometimes can have a lot of, you know, meat and potatoes to it. It really feels like something for somebody. The second time, it's less novel. Somebody's already kind of done this before. They're less anxious on that given day. They're more okay with the idea of letting go, not only consciously but unconsciously, and sometimes they just go a bit deeper. And when someone goes a bit deeper, if that dosing is so constant, not titrated back, sometimes there's just a little bit more of a lapse of memory associated with it too. So in other words, the deeper you go, the less you're probably going to retain. And so the long story short of that is, in these more fully dissociative states of the ketamine experience, it could be that somebody just like actually had a full experience, they just don't remember a lick of it afterwards. And so it could be that they came in for their second one and that effect happened, whether it was IV, oral, or otherwise. And there's always, of course, your random other possible causes if some nurse just forgot to put some ketamine in a syringe at an IV clinic or something like that. So, it's, a slew of reasons, but that's probably what happened with that person. Was either that a very different experience, deeper experience, some bioavailability concern, or just literally the random, I got a completely different ketamine experience than all the other ones that I've had, and to me that feels like nothing comparatively. It kind of depends on what the marker of what an experience, an achieved experience is for somebody,
Can certain medications make someone feel like they didn't have an experience if they took it before? Yeah,
exactly. I mean, that's another one too is, let's say we advise someone to hold their benzodiazepines and then they didn't, they forgot to, or their Lamictal or something like that. Some medication might play into the effect of ketamine. It could be that. I mean, sometimes we just forget to not hold, and somebody, actually, in fact, had, taken their Lamictal when they should have held it, and then just kind of had a really lackluster experience. So there's a whole slew of things, but there's a reason why I do a series. Some ketamine clinics start at a very specific dose and they just escalate from there until they get to the point where basically it's too much for someone, and they go, let's back it down from there. And then, so basically if you did 6 infusions, you spent 3 trying to get to a therapeutic level, and then you overshot one of them, and then you kind of dialed it in by the end. You maybe got 4 out of the 6 that were decent enough levels to work with. We try to do that all in the first session. So we try to get the dosing perfect on number 1. That way we're off to the races we already have a good therapeutic level. So I guess for a lot of people, when they're going through ketamine treatment in a clinic that has a paradigm of dosing more around that, and you kind of have to do that with things like oral dosing, intramuscular dosing, you can adjust on the fly. I mean, with intramuscular, you can stack small doses, but similarly, you could do multiple oral ketamine administrations. But the point is usually they just pick a dose, try that, see how it goes. And, if that didn't really work, try a different dose. Oh, we overshot it. Okay, now we have an idea where we need to be. There's usually some degree of process around ketamine treatment with that in most places, unless they're doing, kind of real-time dosing by IV. So that's why we do it that way. That way we don't have to waste somebody's time by them coming in and having a really lackluster experience. Because if we're in the midst of that, we just turn it up in real time, or if we're in the midst of it being a bit overwhelming, then we can turn it down. So, it could be a whole slew of things why somebody just didn't experience anything.
Okay, so I used the restroom before my session, but was distracted by my bladder about 1/3 in or so. Is that normal?
Yeah, so, what I would do if I were going to undergo ketamine treatment is you want to be hydrated, not only for processing the ketamine through after, that you have, if you're doing an IV, that way you can actually have some veins prominent when you come to the clinic. But you don't want to be overhydrated to the point where you cannot go 30 minutes without peeing. And so now there's a multitude of things there. Sometimes a facet of people's anxiety is, needing to urinate regularly. So, obviously the best thing to do is go right before the actual session start, get in the chair, do the infusion, and then as soon as someone can walk, go to the bathroom again. If they're one of those types that it literally is a 30 to 45 minute thing, in and around a stressful event. The reality is that, so if you drain your bladder right before the ketamine session, most people will generate about 1 milliliter of urine, every minute. That's normal urine production in the bladder. So at the end of 30 minutes, you have 30 mils of urine in your bladder if you truly eliminated it. And so if I showed you 30 mils in a little cup, you'd be like, that's nothing. That's literally almost no urine whatsoever. Some people are like, well, I produce a lot more than that during ketamine. Yes, you actually do. So when someone undergoes ketamine, there's a couple of things going on. Blood pressure, heart rate increase, they perfuse more, so they naturally make a little bit more urine. But also your body's kind of trying to eliminate this thing, so that goes up. And naturally the pH of ketamine, once it's in the bladder, because a certain amount of ketamine just goes straight through your system, right into the bladder. Like, I don't think anybody's concentrating pee out there to get ketamine from ketamine clinics or anything like that. But theoretically, a certain proportion is passed straight into the urine, and so that's a little bit irritable on the bladder. So that effect is coming from there being a small amount of increase in urine production during that period of time. It's a little bit irritable in a different pH. Your body wants to get rid of it. So, long story short, if you mix all of that with also like coming in overhydrated, in other words, some people, that is kind of like a comfort for them, like just constantly drinking water. I've seen that, like they're a little bit nervous for a session. I'm like, I just saw this person almost drink like a gallon in like 15 minutes here. What's going on, But I guess my point is, of course, that's going to be distracting during the session. That means that I've never so far seen anybody actually urinate themselves during a ketamine session. So if that was a concern for someone, I've seen patients that was a concern where they were like, let me just put it depends on. That way, just like, if it happened, I don't have to think about it. And it's, of course, like way overkill.
I see that as like a sense of control if somebody's so afraid of urinating themselves, obviously, in public, and that not letting go probably in the experience is probably pinpointing them to like, oh my gosh, I gotta use the bathroom. It's like,
yeah,
it's hard to lose that sense of control with your body.
And there's some states where like a sensation in certain areas of the body, more womb, pelvic region, etc. Like this could be something else entirely too, and it just being kind of signaled in on that. But long story, ketamine does make you need to pee, and if you're not pretty careful around what you do with your water, then you're either not gonna be able to get an IV placed, or you're gonna want to pee right in the middle of the session. So the best thing to do, drink water like normal throughout the day, avoid any stimulants. About an hour before you come in, that like kind of little window, you can stop drinking water during that period of time, other than little sips. Pee right before you get in for the actual infusion. And if it's an IV clinic, setting an IV up with a lock, that way it's so easy to just go to the restroom real quick, pop IV back in, and get going from there. Chances are you're not going to generate enough urine to notice by the end of the session. And if you do, basically, I'm telling you, even if you think you're going to pee yourself, and I've had patients who were very convinced that they had peed themselves. They were just like, well, it happened. Sorry guys, this just happened just now.
And they didn't.
And we're just like, you didn't. You're. I know. Maybe it didn't actually happen, and they're like, I'm sorry that it happened. Like afterwards they're like, I didn't. I swear, I thought I peed myself during the experience. We're just like, yeah, I know. We're telling you didn't, but it's okay. So I guess my point is there can just be odd sensations on ketamine in general, and if you're feeling anything in your body, people under ketamine can even like literally have like homunculus sensations in the body where their hands feel really big and their tongue feels really large, and it's kind of a more rare thing to see, but dissociatives are capable of producing the effect, which is like a whole fun topic, but anyway, sensations can get weird. So sometimes if it's just like the slightest amount of bladder pressure, it can just feel like a lot. So just being smart around all this. But and again, we do a series of these for a reason. If you have one where you're like, I was pretty distracted by my bladder the whole time, okay, well, let's be smart about what we do around all that.
If you do pee during a session.
Just do it with like charisma. Yeah. Do it, like just get into it if you're gonna pee, because if it's gonna be our first, like, make it a story. All right,
next question. What are the effects of the eye mask?
So definitely important. The effects of it are, one, it minimizes nausea because there's a slight effect of ketamine to cause some nystagmus. And nystagmus is just the movement back and forth in the eye. A lot of people are aware of it from like they've seen where they have been pulled over by the police, and the police officer checks the vision back and forth to see if there's some jutting of the eyes that is indicative that somebody has or is maybe intoxicated. Well, that happens with ketamine. When someone's under IV ketamine, in the doses that we typically, that more paradissociative range that we typically work in with KAP, it's not very strong nystagmus, but it's there. you will see heavy nystagmus and fully dissociative ranges. That's one of the markers of full dissociation. In other words, when I worked in the emergency room, when I was seeing somebody that had pretty good nystagmus, I could very well bet that they were probably unconscious enough to do a procedure on them. So it's one of the markers for dissociation. The point of that is that, if your eyes are moving back and forth and you're trying to like stare at a given object, whether it's TV or something like that, you're probably going to get nauseous. I mean, just like being on a boat and everything's moving, eventually it kind of gets to you. Some people are more susceptible than others, and ketamine's the exact same thing. Things are moving. It's very difficult to track things with your eyes, and then ketamine just, some people just get ketamine nauseous under it for no reason at all, just due to the way that they kind of metabolize it. But long story short is it's going to internalize the experience. The closed eye visuals will be more prominent and easier to pick out. The experience is just going to be more full with eye shades. So part of being in a dissociative experience is not grounding yourself to the reality that you're in so that you can go fully into that experience. And anything that you're doing to ground yourself to this reality is going to fight that process. And so whether that's grabbing the chair to make sure that you're in fact still, have a body, whether that's, process like looking around the room, to just like what's going on. The more of that somebody does, the less internal that experience will be, the less experience they'll have. I've literally had situations where I was trying to gauge the level of ketamine that somebody was on, and I asked them, and I get kind of a confusing response, and I'm like, look, close your eyes. So they close their eyes. That probably sounded like, like close your eyes. I mean, in a gentle way, like try closing your eyes. Anyway, so, and then someone's just like, wow. As soon as they close their eyes, it's like someone was having a completely adequate ketamine level, and they just like literally were having no experience at all looking around the room, like totally locked in on this environment. So sometimes just the ability to just shut that down, and then so when we just like, and what can happen to people is they get the one eye open, one eye closed kind of thing going on, right? So they're trying to close their eyes, but they really kind of focus on something else, and they just start like kind of having one open, and then you get some nausea from that, or some light leaking in, or whatever it may be. So just locking it down with some eye shades and not needing to worry about it, it's totally the way to go, just to kind of have the greatest effect. But again, not the worst thing in the world if someone needs to open their eyes the entire way through.
Why do you think it is that lots of infusion clinics have like TV for them, like Netflix or nature backgrounds or whatever?
To each their own in their own shop. I mean, if you're trying to just do ketamine infusions on somebody and you don't have any therapeutic component, there's no plan to do it like that. You're doing this from a surely biochemical means. I mean, it's better than sitting and twiddling your thumbs for somebody if like you're just not encouraging the experience whatsoever. I mean, there's clinics that even say like, this is like, this experience is not even a psychedelic experience. Like they just literally like don't even term it that way, or like, or talk about it in any way where it even sounds like it would be psychedelic, or psychoactive in any kind of way. In other words, they'll be like, oh, it'll be a little floaty. And it's like, well, then somebody actually experiences it, and they're like, well, I'm feeling a lot different than really floaty. In fact, it's, I mean, I guess my point is like, ketamine can produce things like ego death for people, and really significant, experiences where people completely forget about this reality and then, come back and need a lot of grounding and, support during this process. And so if you just like are dosing in ranges capable of producing that, and then you're just like, you got 5 people and you're just like, let's put a TV on, like this whole situation, I'm just like, I get that there's maybe money in that or otherwise, but there's almost no argument for any of this stuff. Like, it's just, well, I mean, I guess accessibility, whatever, like trying to make it cost effective for people or otherwise, but this can be done really well when it can go really right when it's done well, and it's just not that difficult to do well. And a simple pair of eye shades is like one of those things that is like, why do more places not use eye shades? Like it's such a big deal. They don't even present it as an option. In other words, people will be like, hey, I read online that I could like maybe wear eye shades, and they're like, yeah, if you want to, but we got this like 4K drone footage if you rather check that out. I mean, to me, it's just like, and again, I mean, we have a projector, and we have used that in very rare cases where that was like the smartest thing. We felt that somebody that kind of letting go too much in the first one, nothing to ground to, and then that visual would be important for them. But man, there's almost nothing perfect to watch under ketamine. I mean, no matter what we tried, if it was nature scenes and the mountains would come up and someone would be like, well, that reminds me of the last time I was in the mountains with my husband before he died. It's like there's just nothing that's not triggering for somebody under a certain state. Like, if it'd be anything. I remember we had one with some birds in it at one point or another. Well, when you're under ketamine, you see a bunch of weird reptilian birds. Like, sometimes that just gets spooky. You know what I mean? So when you're seeing that in normal consciousness, you're like, oh yeah, birds. That looks peaceful. Somebody might want to watch this under ketamine. And then you actually show somebody, and they're just like, whoa, those are scary ass birds, you know what I mean? And same with music. I mean, East Forest, I love East Forest, but he puts birds in all the music half the time. There's so many birds and so many songs. And then it'll be like a million crows going on at once, and people just be like, is there birds in here? And it's like, oh damn, that song was perfect right up until that bird part. Anyway, I don't know if birds and ketamine get along, is what I'm getting at, so.
So one is basically very sensitive under the ketamine state, basically.
Yeah, and I think, somebody who's staring at TV the whole time is less likely to have a more internal experience where they're really focused on what's going on. And that may be the thing for the day that somebody needs. Again, that's just super rare that's the thing. Probably going to experience more nausea. They're probably going to experience a needing of more ketamine to produce an effect that's even recognizable for them. Because sometimes people will literally just be like, I don't notice much, close their eyes and be like, my God, so it's just such a on-off valve for the experience, just the visual input. As soon as that goes away, it definitely deepens it, pretty significantly. And again, that might be too much for someone, so that can be a reason why somebody wants to look around. But in front of our ketamine chairs, we have like literally a white wall with nothing on it. There's just absolutely nothing there, because you will see. It would be the crappiest painting on the planet. If you put it in front of someone, it's just going to be the most amazing painting on the planet. And so then they're just solely focused on this really crappy painting for like 30 minutes. They're just getting nowhere. So it's better if there's just nothing distracting in front of somebody. At least for us. Or maybe, that could possibly be used to prime something very specifically. Like maybe there'd be, people talk about like VR, right? Like doing VR therapy with this. First of all, I don't think ketamine and VR pairs very well because of nystagmus. Like the VR effect largely goes away when your eyes are jutting all around everywhere, so it's probably going to be fairly nauseating, confusing to be under VR and ketamine specifically. Maybe other psychedelics fare better. But the long story short is we'll see. Maybe, and again, you could probably use technology to adapt for nystagmus, but the long story short is I don't know how much. For me, if we're talking about doing dissociatives, the goal is largely to let yourself be taken by that experience, and just anything that's going to ground yourself in this current reality is just not useful for what the goal of that specific agent is. And so I don't see like VR or TV, any of that having any utility for most.
At least for the therapeutic effects. If that's what you're into. Alright, so I'm planning on doing 3 infusions back-to-back days. Is that okay?
So, if that was all that you could figure out, you're flying in for a portion of time at the one ketamine clinic local to you or something, sure, do it. But, the reality is if I was in that situation, I'd probably just really focus hard on one, Let's just get the most bang for my buck on one of those sessions, really go into it with intention, really try to be mindful about the integration of that more than let me fit in 3. Because I just think that that's more of this biochemical way of thinking about this, how much ketamine can we pump into somebody, to produce this effect, I just think that one infusion is plenty to produce that effect. And so, at least from that standpoint, so I don't know why I can't really come up with a rationale of why we would do that, because biochemically it wouldn't make sense. It's not needed, so it's just overkill. With that, nothing is without risk, right? Ketamine is extremely safe, but at the end of the day, it's still a medical procedure, and everything comes with its associated risks. Every time we go into the ketamine state, that again is a psychological risk for somebody, particularly if they're doing it unsupported. They're just going and doing a ketamine infusion. So, I just think there's a lot more reasons to not do that than to do it. So I don't know why anybody would be encouraged to, but it just, to me, it sounds like we're trying to run. So I have an analogy around this, if you had to run 3 marathons in a week, right? Could you do it? Well, somebody, maybe, if their life depended on it, right? So if someone's life depended on it and 3 infusions might change that, then yeah, that'd be an answer for, okay, let's do that. But why are we in such a rush? Like, it took a lifetime to get to this place. Why do we gotta fix it in the next 3 days? Like, I don't know. Sometimes I see people get in this situation and I'm like, oh, let's just be more mindful. Let's space this out more. Let's do this right. Because very oftentimes, I don't know. I mean, I think Paige has heard me complain about this a million times, but like comparisons, like, I don't know, when we go to the dentist, we're not like, I don't know, can you just actually, like, I know you were gonna put my braces in this way or we do this with my teeth, but like, can you just actually put my molars in the front and my, my incisors in the back, that sounds cool, I guess my point is, with plans of care, sometimes there can be like substantial reasons why we do something one way or another, and so much literature support a specific way of going about it. And so I think sometimes when patients will be like, can we do it like this? It's like, to me, it almost sounds as ridiculous as that. Like, no, you can't have molars in the front. Like, yeah, you'll still be able to chew your food, but like, it's gonna be really weird when you have molars in the front, right? Like, nobody does that. Like, theoretically, we could shift your mouth all the way around and do all this stuff, but like, why don't we just do it the way that most people's teeth typically go anatomically? And, I guess my point is with this weird analogy that, I think there's usually a reason why we kind of go through this in a very specific way, and there's kind of inherent, problems that come up with trying to deviate too far. Some deviations probably fine, but and you should be deviating with each patient that comes through, the ketamine clinic, as a clinician. But when people just are like, I want to do it like completely different than like very oftentimes it's like, well, maybe it's just not the time and place to do it then, or maybe it's what it is. But usually what that is just that someone is very anxious and they've read a lot of weird information and inevitably they just kind of want some control over the scenario, and so because it's a fairly out of control scenario feeling to somebody, and so they'll want to like really rigidly go through it in the way that they decided. But I so oftentimes see that stand in the way of patients. In other words, there's nothing wrong with somebody bringing in their own music, but I just think fundamentally, like, the more someone can just give into the process, like listen to our music, do it kind of through this more rigid way that we do it. There's a lot of reasons why it's the way that it is, at this current stage. And so, I would encourage people to try to trust the clinic that they're going to see in the way that they normally do things and proceed through like that. Now, if that clinic was saying do 3 in a week, that's probably just because their doctor's like only available on these days or something like that. And, maybe that's just the best way it can be facilitated at that place. But generally speaking, I would say that we actually have good data to suggest you don't do that, because we do know 2 days a week versus 3 days a week, we know no difference in clinical outcomes from just a sheerly biochemical standpoint. So why even do that third one?
Yeah. All right, so at home versus IV ketamine. So I've been doing IV ketamine in a clinic, but I just don't like a lot of the factors that are involved, such as the $50 Uber ride home, feeling nauseous, blah, blah, blah. Thinking about switching to at-home ketamine.
Sure. I can never say that that's the, not the best thing for someone. Ketamine assisted psychotherapy may not even be an option for someone in their given area. They may be in a really rural area where a ketamine clinic is very far away, and I do think it's funny, inherently, if someone's in a rural area where they're really far away from a ketamine clinic, they're probably also really far away from EMS. So it's like, if you're on a couch and you're dealing with a medical issue that came up from oral ketamine administration, you're also like really far away from any medical help too. But I guess you could kind of make an argument for this, and ketamine got its start in the battlefield for this exact application, but this is let me clarify that statement. It was produced to help to be a pain medication / anesthetic in the battlefield where it didn't need monitoring and could be used in like kind of more austere settings like this. So it's not completely out of the, realm of things. When I gave ketamine in the field, sometimes someone would be in a car, and it's all crumpled up, and all I can do is sneak in there and give them an intramuscular shot of ketamine so that they're in less pain. low doses, by the way, people, not psychedelic experiences in a wrecked car. That is not, that's not okay. Anyway, so long story short, I think that in relation to the idea of switching from home, that might be the best for somebody in a given situation. But again, I think this just comes down to, how is this being utilized? Is it being used as something, an amplifier of the therapeutic experience? Is this purely biochemical? Because if it is, maybe that is the smartest thing for somebody. But the question is somebody going to be able to actually have an environment that is conducive to them doing this? In other words, are they going to have adequate support, by a family member or otherwise? I mean, the medical support's probably not going to be there unless they happen to be married to an anesthesiologist or something like that. But I guess my point is, generally speaking, there's just not, I think that is probably an extremely common question. Should I just do oral ketamine at home? Because there's so many companies that want to give me, they advertise, I'm seeing 17 ads a day. As soon as I went to a ketamine clinic, I'm starting to get 17 ads a day from some place that wants to prescribe me oral ketamine, and they're pretty aggressive about their marketing and pretty good at convincing people that that's what they need to be doing with their lives. And so I guess my point is that generally speaking, it's better to be time limited in this venture, focused on the therapeutic aspects of this. That being said, there are probably some people that biochemically really respond to ketamine, and it is the smartest thing for them to undergo it in that way, with all things considered, price and accessibility and everything else. But man, my suggestion, if somebody was going to do that, would be to go do it in a supported setting first, gain some comfort with the entire thing. That way those associations can be built. That way it's more likely that somebody would have a positive experience doing it at their home. But very oftentimes, if there's not good support, a different setting will change the experience entirely. You change the song when somebody's under ketamine, and the experience is different. You change the people that are with them, the experience is different. You change the time of day sometimes, and the experience can be different. You change the entire setting to home, and you're going to have all kinds of things. Maybe somebody struggles with just not thinking about work during their ketamine experience. It's well, what are the odds of that if someone works from home and then, I guess my point is in relation to the productivity of this, sometimes that can be such a hindrance. But that being said, if you're going to do in-home, there are places that do, in-home, we do IV Ketamine Assisted Psychotherapy, where we can bring a nurse that can administer, keep someone safe, and we bring a therapist that can guide. So the best of all worlds, But there's inherent expense that kind of comes with dispatching providers to site, and there's no real good way around that. So I get the argument for oral ketamine prescriptions, and again, this process is not the same for everybody. So there may be some people that totally makes sense for, but I would just say, given my experience, the patients that we've seen, and that may not be a good distillation of normal patients, because we may see people who are more trauma afflicted or more in crisis than others, but we do not have patients that I feel like that would be a positive thing for them in their life to regularly do ketamine sessions at their home on their couch.
Yeah.
So.
Yeah. That is a great point, though, of the patient population that we happen to specifically see because of the way that we do IV therapeutically. So.
Yeah, if somebody was more middle of the road and dosing was a little bit lower, and they had to try other things and nothing had really been useful for them, then I think as long as dosing is controlled and there's somebody there that is trusted and safe to support somebody when they're in that state, they probably can go just fine. And I think I see ads from companies that do oral ketamine prescription with comments of people like this saying, "This saved my life." I'd love to see what the long term for that person might look like. I guess my point is people will report stuff like that sometimes, immediately after their first oral ketamine experience the next day. They're like, same, and then 3 weeks later, it's not really working for them anymore, and they're just kind of back in the same hole. And you don't see that comment, right? You don't see they're actually update on it saved my life. It didn't save my life. Still in the same hole. Anyway, yeah, I don't know. I guess my point is that my guess is that you're going to see, the effect that we typically see in the studies when you just administer ketamine in a really biochemical way is that it's a transient, difference. But again, for some people, that may be a really useful thing to have a transient, difference come about in their condition. So, if someone's suicidal, I'm sure during the pandemic, there was a lot of people who got oral ketamine prescriptions who were suicidal, who are now no longer suicidal today and in a completely different place in their life, where the entire thing was a total win, and were helped by that process. But I just think in general, it can be better medically supported, and it can definitely be better therapeutically supported than somebody on like Zoom. I don't know. I don't want someone on Zoom kind of like speaking mean. I mean, if it's the best possible thing, but like, what do I experience doing Zoom? When we did ketamine assisted psychotherapy, where I would do the infusion, we had a therapist on telehealth because of like COVID. You get like Wi-Fi connection issues, you get like all kinds of problems. Yeah, the therapist is like, like if somebody's like having like a really, big thing happening, and like the therapist doesn't even know that they're glitching, so it's just like, you're just sitting back watching this like, not perfect scenario here where you're just like, get this, computer therapist out of the way here, like, let me just talk to this person. Jesus, what are we doing? And so long story short, I don't know, the whole telehealth monitoring is better than nothing, but I sure think that there's definitely something to having a person there when you're under ketamine. So sometimes a handhold during the ketamine experience is like the biggest possible thing ever. My God, it's so like, people can get to a state where it's a bit confusing, time is very different, all things are very different, and they just need a little something for just a brief moment of time of just like, the therapist will oftentimes just be like, would it be okay if I just hold your hand right now? And just that is like instant, like, you see vital signs get better, you see, way less anxiety, you see somebody tolerate it way more. Sometimes that tether back to this reality of a handhold from somebody that they know that they can trust. And again, I always talk about this subconsciously versus unconsciously, but for me, I think that trust has to be like, there's a reason why we do an intake in the way that we do, so that we can be building that trust and rapport up enough so where that when somebody's like, in other words, if they were working with Anna, the therapist, they don't really remember who Anna is or anything, but somewhere deep down they know Anna's like, they can trust them. So that way when Anna says, no, you're safe right now, I'm watching you breathe, your heart is beating, everything's cool, they don't even remember who that is, but they know that person is safe. And so if that association is like really strong, that statement and that intervention goes completely different than if it was just like literally somebody random that they didn't really know. They'd be like, who the hell is, and they can get, certain degrees of ketamine experience can be needing a level of support like that and literally needing your hand held, through it. And so, and it's just, oh my God, it's so funny how much it helps, to just have a little bit of touch. But physical touch is a whole topic for a conversation in the psychedelic medicine industry. I've seen more like wearables coming about and stuff like this. But I just still tend to think that there's something that is like this weird unspoken thing when a real person in real life is speaking to you, telling you they're okay, and you met them before, and you know that they're trustworthy, and that's about it. You don't even really remember anything out of them, and this actually means something to you because somebody that you couldn't trust, they could be like, you're completely fine and everything's safe, and like the person is hearing something different almost, I remember hearing a report of somebody talking about going to another clinic, and they like, I guess were like kind of standing over them and like discussing their blood pressure and like kind of administering the medication up a little bit high in the IV line, like above them, sort of towering over them, and they were just like these, demonic creatures standing above me, and this was my funeral, and like they couldn't figure out where to bury me, and like they were discussing this. And I think for me it's like that's a classic example of like that trust. That's probably the first time ever meeting that person or seeing that person or whatever else it may be, like that. If there was an association built there around safety in the intaking process with somebody, they probably would have like comprehended that whole situation a lot different. Like they're taking care of me, and these great figures above me are like, might have been angels for you. I guess my point is like there's a real need to solidify somebody feeling really, really safe in someone's care prior to getting started with this. And then when you're talking about just doing this alone, like I'm just like, I have no desire personally to do ketamine treatment alone. You know, it's just, it can get a little, I don't know, you can just need support during, you know, and that's different for everybody. There are people that totally can. I mean, obviously there are people that just use it recreationally alone all the time. There are people who can do a lot of different things, but people who have complex PTSD, OCD, severe states of anxiety, there's so many of these instances where people are going to need a lot more support during, careful dosing, about not moving somebody too deep too quick, you know, and just being really careful with this process that you're just not going to be able to get with a whopping oral dose of ketamine on your couch at your home. Like there's just, it's the potential for that to go bad is like, you know, it's leading with your chin, right? You're like walking into a punch, you know, you're just like, let me set up the perfect scenario for me to like feel unsupported and scared and confused and not knowing what's going on in this place that, you know, is kind of some, you know, place that I'm regularly, you know, depressed in or having certain types of thoughts in, and like just, yeah, the whole thing of going to a different clinic with people that you can trust and everything, it will produce a very different experience. And so, yeah, like I said, ketamine's different with a different song on. You change up too many other variables, it's going to be real different. So you can't expect a similar type experience in a safe environment, you know, by IV in a clinic as you can oral ketamine at your home in an unsupported environment. It can go in a completely different direction. So, and it may go good. Who knows? Like, it's up to somebody to decide, but the odds are not stacked well.
Alrighty, I think maybe one more question.
All right, one more.
Yeah. And this is just part one of Reddit facts comments. Whatever. So one more before we go. Less is more, is that a thing?
Okay, yes.
That's a good one to end on.
Yeah, that's a really good one. So what's interesting, I did a whole podcast on the ketamine dosing levels. So check this out. In the event that you want the real nitty-gritty details of like specific, you know, 0.3 to 0.6 is like this and da-da-da-da. So on the more must be better, you know, less is more, this whole like paradigm. So it's really easy for clinicians when they're not having a response for someone to just be like, let's give them more. Let's give them more. If it's low on working, let's give them more, you know. But ketamine dosing doesn't work that way. So there is a ceiling on it, and where there's just diminishing returns. Most psychedelics are that way. So, you know, there's a therapeutic range where people will do a lot of good work, and there's kind of multitudes of those. But at a certain ketamine dose, someone just becomes fully dissociative. And what I mean by that is they are unconscious. You have rendered somebody in an unconscious state. The lights are on, but nobody's home. They're breathing, their heart is beating, but you could probably walk over to them and just poke their eye, and they're not going to do anything about it. That to us is not really like a useful range, you know. In other words, if the therapist is like in the room and then me as a medic like put somebody in that state of consciousness, the therapist would be like, well, how am I supposed to work with this person now? They literally like I could poke them with a stick. What'd you do? So I guess my point on that is not only kind of experientially as they're like really deep ranges of ketamine we very oftentimes don't recall, and it may not be necessary to recall, but very, very deep stages, sometimes there's less fruitful territory and less ability to use it for KP if you're doing intra-session work. Again, there can be a reason why you would administer deeper ranges of ketamine or even potentially fully dissociative doses, but you know, with this there could be arguments around all these things, but generally speaking, most people will respond to a kind of more middle of the road, you know, experience where it's somewhat challenging for them, but not overwhelming. You know, so I like to say a full experience that someone's still able to talk to their therapist at any time if anything comes up, that allows them with enough of their faculties and not a high degree of confusion where they can actually do therapy around things that are really happening in their real life. So in other words, the idea of their ego, there's enough ego left where it could be relevant. If then again, like I said, it may be useful in someone's therapy for them to go beyond those states, but generally speaking, most of the work will be done in that state where someone is having a full experience where they're still able to talk with their therapist, and there's a narrow band for that can be found with appropriate dosing. But beyond that, and I mean, the window is like not that thick, you know. For some people it's super thin, some people it's a bit wider, but you know, in other words, some people can be in a very deep state still talking to a therapist, and some people can be like, they just get in the shallowest waters and that goes away, you know. And so I guess my point is finding that band is usually what we're trying to do from a dosing perspective to allow, and I think that's multifactorial. So one is that a lot of people do intra-session therapy. You know what? They do a therapy session during the actual ketamine experience. It might be a weird way of talking about it, but I guess and then the other thing is just if any time somebody like just wants to stop, or this is coming up for me and I want to talk about it, or like please jot this down, or whatever else it may be. I guess my point is that ability goes away if you dose too high. And so you can run into a situation when you're dosing that high where someone was having a horrible experience the entire time. They totally didn't want to do it anymore, and you didn't find out until they came back. And that's not something that we do. I mean, we don't play that game. If I can't get, you know, I tell patients on intake, you know, we're always going to be able to talk to you. If at any time that starts to break down or it's too difficult to talk to you, at minimum, give me a thumbs up. If I can't get a thumbs up that you're good to go, we're going to lower the level of experience to the point where you can talk to me. So we never have that drop off. And if you never have that drop off, then your reverse reaction rate is like zilch, because people are only ever going to the level of their comfort. If anything comes in at any time that they're not cool with, we can just lower the level. And so, you know, just stop that. Or it could be worked through therapeutically, depending on the situation. So I guess my point is less is more, for sure. And then another aspect of that would be like the more chemical aspect of, you know, if we have study dose ranges, you know, so generally 0.5 to 0.9 milligram per kilogram is, there's pretty good study to suggest that's probably the most useful terrain. You're probably going to see different conditions where they, you know, like, oh, maybe elderly, that's this, or maybe for OCD, this is a better range. And there just has to be a lot more study around this. But, and I got a lot of ideas, but long story short, with all of this, you know, fully dissociative ranges to me, like maybe there's some utility. I see the problem is a lot of people will say, oh, I dissociated, or like, in other words, they'll have like basically just a psychedelic experience and they'll be like, I dissociated this time, you know, and it's like, actually it's kind of like a middle of the road, you know, wrong of dissociation. In other words, like to really quantify what was happening for someone, you know, some people will call experiencing ego death dissociation, and some people will call just having psychedelic effects dissociation, because that's like the term that they can think of to use for it. You'll even see like ketamine clinicians doing this. But these things really do have kind of identifiable terminology and, you know, rating scores for, and all these kinds of things. It's not as big a mystery as it should be, but I think the term gets used wrong and overused all the time. You know, and then there's terms like psychedelic don't really mean anything at all. So, you know, and they sure have a questionable, you know, meaning. And so I guess in relation to, you know, what is the most useful range, I could probably know based on the studies of just like, the beauty is because so many studies are just ketamine infusions, we kind of have that side fairly rated in, right? We're like, got a lot of studies on just doing ketamine infusions for various things and seeing like which dose ranges and whatnot respond, because that's like the only variable that they're looking at, and trying to control for these. But I guess the point is, you know, I think that therapeutically there's a useful range. I think that biochemically there's a useful range, and it really is the fact that just like vitamins, you don't just take the bottle, like there's a dose for it, you know, and, you know, beyond that it's not there, and it's very common for someone to think like, well, surely I, you know, just need a higher dose, you know, this week or whatever else it may be. But a lot of times, anytime I've ever seen that we actually like appeased that, you know, concern, like, hey, I had a really stressful week this week, like maybe I just need a higher dose. Well, then they end up with a completely different experience that was not like any of the rest, and they like, it wasn't as useful therapeutically, and someone almost ends up feeling like, man, I shouldn't have said anything. And so, anyway, the long story short is there's definitely a variable of too much more is not better in ketamine treatment. And I hear that, well, how much ketamine do y'all give compared to this clinic? They say they give like this much ketamine. I'm going to get more ketamine, more bang for my buck. Well, more ketamine is not more bang for your buck. In fact, what's really weird for people sometimes is when they go to another ketamine clinic and they've got, let's say they got like 2 milligram per kilogram over an hour by IV straight infusion. And then they come here and we're like, hey, we're going to give you like 60 milligrams. And they're like, wait a minute, it's like way less, ketamine than I got at this other place. Like, can't y'all just do the dosing with this other place? And I'm like, let's just see how it goes with the way that we do things. And we dynamically dose it and we achieve a more moderate range. And someone comes back and they're like, that was so much more intense than the other place. And I'm like, well, yeah, because the middle range is actually something that you can come back with and you can remember the intensity and you can actually work with the experience to some degree. And that comfort is so much greater because you actually are right there with a therapist, so you can kind of feel free to kind of navigate in it versus white knuckling your way through it or whatever else it may be. So you can just go into it more. There's so many different ways of thinking about it. But I guess my point in this is just that, there really is a ceiling to the dosing effect. Sometimes that's elected for patients that I must need more, and sometimes it's the clinicians that are more must be better in this given situation. There's one area where more probably is better, and that is in chronic pain. In chronic pain treatment, oftentimes the more ketamine you kind of give somebody, very oftentimes the more pain response, the longer that they get out of that. But there's probably diminishing return at some point for that too. But generally speaking, super light dosing in chronic pain is probably not a extremely worthwhile venture for the majority of people who have severe chronic pain issues, and making sure you're getting an adequate dose is definitely advisable. Otherwise, you probably won't make an impact in it. So I guess my point is and also I almost wish we were in a situation where we didn't discuss dosing ever, because I think dosing is such an extremely complex thing with so many variables associated with it, about why a clinician might decide, hey, this dose on this day or whatever else it may be. And we want to take the patient's report and also what the clinician saw to say what we should do with dosing, of course, be listening. But how did I just talk about that for 20 minutes or whatever? I just barely scratched the surface on talking about the ceiling of ketamine. So I guess my point is it's sometimes becomes very difficult to actually convey. It's do you want to sit down for a 5-hour conversation about 10 more milligrams of ketamine? Is probably not a good idea. I guess my point is definitely want to be able to convey that information to somebody, but also I hope that patients can trust their providers. They do this all the time, all day, every day. They understand all these variables. There's a whole lot of research that most people are not going to want to dive into. And just like you don't ask the dentist to put your molars in the front of your mouth, I guess my point is the ketamine clinicians kind of understand a lot of variables that inevitably, but it's definitely, telling someone, hey, that felt like a bit much for me. If you're getting a response of, well, you still need to increase the dose, they're not listening to you, and that's not going to be useful. So I guess my point is hopefully we don't have that situation going on with people, but I do think sometimes that does happen, that there will be a dose escalation that happens with patients that was not warranted, and that there's this idea that we got to get more and more and more, ketamine, and we got to get over 1.5 milligram per kilogram, we got to whatever, there's these crazy ideas that kind of come out of this industry that doesn't have a high amount of standardization yet. And, just because of what this clinician's seen in their shop. But I guess my point in all of this is there's definitely a ceiling for the effectiveness for ketamine. More is not better. If that was the case, if more was better, we could just administer hundreds of thousands of milligrams of ketamine to somebody and just keep them unconscious for a week, on a drip in the ICU, and intubated on a ventilator, and then wake them up and be like, is your depression gone? If it worked like that, you know what I mean? Now there are long-term ketamine infusions for chronic pain disorders like CRPS, but I guess back to the mental health side of this thing, it's not just a game of how many milligrams of ketamine can we administer to somebody. You put a certain amount of gas in your car. You want a therapeutic level achieved that will produce a specific response. More than that does not necessarily produce more of a response, and you're just going to see more, side effects usually. So you go really, really high, and man, it frustrates me every time. We've decided, hey, let's really increase the dose for. A lot of times, as you start to exceed like 1.2, 1.4 milligrams per kilogram, you get like the possibility that someone's going to get like profoundly nauseous afterwards, or like really have a lot of secondary side effects from ketamine start to go way up. But not every time. Some people just surface that just fine. Obviously, we give really high doses of ketamine in the ER all the time, and people surface that just fine without too many side effects. But I guess my point is, in this setting, when it does like launch and someone's just like nauseous for like 4 hours afterwards, you're like, man, if we just kept dosing just like literally 10 milligrams, 15 milligrams less, we may not be dealing with this. And like, what did we get out of that extra, like in the experience, I'm not seeing any like huge gain from this slight difference in our dosing, but I definitely saw a huge negative. So yeah, there's a window to find for somebody. And the cool thing about ketamine IB is that with every variable that someone could possibly have, genetic variation, other medications, whatever their diet is, all of these things, generally speaking, people's doses fall in a pretty standard window. It's kind of interesting that, when you're going through like the narcotics log and looking at every now and then you'll see like one anomaly. But it's so rare that you see somebody like not kind of in between, 40 and 100 milligrams. Most people will be in that range in the way that we do our dosing. And again, we dynamically dose. So if someone was getting a longer infusion over the course of time, or there was, it's intramuscular, et cetera, like these are not comparable. Like in other words, that dosing that I just said there, that could have no grounds on a longer course of, in other words, a ketamine infusion over a long course of time, oral administration, IM administration, these all have different bioavailability, so that dosing is very specific to dynamically dosed IV ketamine that I was talking about at our clinic. But again, so there's a lot of variables there. I guess that answer is more better, because I could go for like 2 more hours of that.
So
It's
much.
more possible better. So we'll do another one of these coming up.
There's probably many parts to these because there's a lot of questions.
There's a lot of Reddit questions, and I think that every one of these is like, it's entertaining for me to rant on whatever comes to mind when you say one of these questions. So I think this could be really useful for a lot of people, and that way they don't have to endlessly scroll through Reddit and try to figure out what's truth or not. You just be like, here's the question, this is kind of a general answer, something comes from it, and hopefully I answer some other questions along the way.
Yeah.
But with that, if you ever do have any questions about ketamine treatment, you want to speak to Paige, she can definitely reach out to our clinic and talk with her. If you're interested in treatment, feel free to reach us as well. And what is our number, Paige?
It is 833-731-3400.
Or you can inquire at info@transcendketamine.com. So if you have questions like this, though, let's say you have like a random question, email info@transcendketamine.com and just be like, hey, can I mix ketamine and DJ Screw? People probably don't know what DJ Screw is, right?
I don't know what DJ Screw is.
It's Houston rap. It's like really slow.
Okay.
So what would be something that's more recognizable?
Like a rap artist with ketamine, like music.
Literally, you can send music. Do you think that that's good? You can send, like any kind of inquiry as ridiculous as imaginable. In fact, send something ridiculous. That'd be so fun to talk about. Mm-hmm. Send a really interesting one.
Yeah, help us be more ridiculous than we already are. We need that help.
Yeah. All right. Well, I like to say until we meet again.
See you later.